Hey everybody, Sean Haaverson here. This is the last segment in our discussion on managing shock patients. We've reviewed the topics starting with our series on shock physiology, the body's response to shock, followed by a discussion on bleeding control and management, and now finally wrapping up with two major topics. We're going to be talking about managing patients in resuscitation with a heavy focus on PHTLS 9th edition topics, including fluid management. In that, we'll talk about managing IV fluids, blood and blood products, and we'll discuss treatment algorithms and perfusion guidelines set forth by the PHTLS 9th edition. We'll also have a discussion around the alternative therapies that are currently in study, including blood substitutes and colloid solutions. And finally, we'll wrap up with a discussion managing trauma arrest. Let's dive in. Okay, let's talk about fluid therapy in managing shock patients. Okay, so we're going to start with some algorithms. These algorithms have been created based on the PHTLS algorithms out of the textbook in the 9th edition. So when we have patients that have external hemorrhage, we want to assess and manage that hemorrhage as soon as possible by starting with direct pressure. If the bleeding is not controlled, then we can elevate to the use of a tourniquet. Once bleeding is controlled, though, we immediately need to move on with our A, B, C, D, and E assessment. So this is essentially the X route for insanguination. After assessing perfusion, and we can find that by things like a decreased LOC, changes in the patient's skin color, and changes in the patient's ventilatory rate without needing to get a blood pressure. All right, so as we go down this shock route here, we can see that we're going to start off with making sure that we've titrated oxygen and ventilatory rate. We're managing the need for C-spine as necessary. We're going to make sure we warm the patient, conserving heat. Again, 85 degrees Fahrenheit, patient compartment. Again, we're uncomfortable, but they should be quite warm. Initiate transport to the appropriate facility, and only then will we move on to IV therapy. When we initiate IV therapy, we want to try and conserve body heat by using warmed fluid that's warmed to a 102 degrees Fahrenheit or 39 degrees Celsius. There's lots of ways to do this and many commercial devices to achieve that. Having warm fluid will make a big difference in our patient's progression towards hypothermia. Once we identify, though, that we need to resuscitate utilizing fluids, some things that we want to remember. Again, can't state enough that we shouldn't start IVs and manage patients with fluid resuscitation on scene. The only case where this is appropriate is in extenuating circumstances that are out of our control, like patients that are requiring extrication from a vehicle before we can transport. In those cases, remember, we still need to be safe in doing that job. When we start an IV in trauma patients, we generally want to start 2 large bore IVs. PHTLS recommends these are essentially at least 18 gauge needles. Now remember, though, that the larger the diameter, so the smaller this number, the larger the diameter and the shorter the catheter, the faster fluid is going to flow. So try to find 14 gauge, 16 gauge, and 18 gauge angiocaths that are short. Again, ideally, we want to warm that IV fluid as we're administering it. In some cases, managing patients with an IO is necessary. Use your local protocol to evaluate how many failed IV attempts, or if any, are required before giving an IO. If utilizing an IO, remember that the fluid should still, again, be warmed, but we want to try and manage patients' pain control while infusing the IO solution. Generally, patients with infused solution into the bone have extreme pain associated with it. See your local protocol. Now remember that we're in expanding patients' volume. It doesn't actually really mean that the patient is increasing their oxygen carrying capability. So if we want oxygen carrying capability to increase in our volume, then we need something that's very close to blood. And so that could be either actual blood products or some limited blood substitutes. Blood products can include things like packed red blood cells, whole blood, reconstituted blood products, and lipophilized plasma. If we're looking for just volume expansion, or if that's the only resource we have available, then it's limited in the amount of oxygen that it can increase in carrying capability. So generally what we're replacing is plasma, not whole blood. In that case, we're probably using crystalloid solutions, though there are some colloid solutions that can be utilized in special circumstances. Generally, though, crystalloid solutions include the fluids we're most familiar with, like normal saline and lactated ringer. Let's review the different types of IV fluid that are available, and a little discussion on this is available for each type inside the PHTLS textbook. For IV fluids, isotonic crystalloids are crystalloids or fluids that have crystal small structures inside of them, often salts and ions. Isotonic crystalloids are also isotonic, meaning most similar to blood. Hypertonic crystalloids have more stuff in them than we would expect to see in blood. And so sometimes this can have things like hypertonic saline, large amounts of sodium chloride, much higher than sodium chloride, 0.9%. The fluid of choice is lactated ringers in most trauma patients. Lactated ringers is the fluid that is most physiologically identical to patients' blood. Normal saline, though, is a good alternative, and there are limitations for LR we'll talk about in just a moment. Colloids, as compared to crystalloids, have larger structures within them. So synthetic colloids generally have large starches or large proteins embedded in the fluid. One of the most commonly used is hetastarch. Hetastarch utilizes starch as a means of changing the tonicity of that fluid. Hetastarch is a solution that has large starch molecules in it, making it much more tonic or more stuff inside of that water than would be inside blood. Once this is infused, it adds to the patient's blood and draws fluid out of interstitial space and intercellular space to place fluid inside the blood vessels based on oncotic pressure. Unfortunately, though, this can happen in profound volumes and put the patient at risk of tissue and organ damage. Hetastarch does have some benefit and is used often in tactical environments or environments in which the austere nature of the place that the patients are found in preclude having large volumes of IV solution brought in. In some cases, a patient can have infusion of 500 milliliters of hetastarch, and that replace or be equivalent to the replacement of about 7 liters worth of fluid. Unfortunately, though, the patient does need to get to isotonic solutions at some point, as soon as convenient. There are some blood substitutes out there, but very few of them are in the aspect of EMS street care. Some of these are still experimental, others are not showing great effect in patients. PFCs are a blood substitute, and they have oxygen-carrying molecules that can carry up to 50 times more oxygen than a hemoglobin molecule could in plasma. There's really no biological materials in them, so the infection rate or exposure to that is extremely low. HBOCs are another type of molecule that can increase oxygen carrying capability. These are generally oxygen carrying molecules that were derived from animals. Unfortunately, they've not yet been found safe to utilize in patients in the pre-hospital setting. Lactated ringers is the preferred fluid for trauma resuscitation in many cases. It's that way because it has other electrolytes and some pH correcting mechanisms that are more physiologically similar to plasma than normal saline. There are limitations, however, one of the biggest being that patients that are going to receive blood, if we've put on a blood set or we have a Y tubing, patients that are going to receive blood generally can't receive blood in a tube that has lactated ringers. Blood is usually destroyed by the presence of lactated ringers. So if you have lactated ringers and you need to resuscitate it, we recommend having at least one line with normal saline and one with lactated ringers. The line with normal saline would be the preferred line for blood products. Now, since we're generally giving patients crystalloids, the class of fluids that fits within this region does have some tendencies that we should be aware of, especially in longer transport times. When we're utilizing crystalloids, they have less osmotic pressure, so they're going to diffuse across the membranes and the cells at different rates than colloids would. In this process, though, remember that when the patient was going in that progression from having initial decrease in cardiac output and on their way to patient death, they started to move fluid out of their interstitial and intracellular space to go into the IV space. In this case, they've dehydrated their cells and tissue. Because we're replacing fluid and assuming that we've stopped the major bleeding, once we start replacing volume, that fluid eventually is going to go back from the inside of the intravascular space and leave going into the interstitial and intracellular space. This can occur within 30 to 60 minutes, in which case 2/3 to 3/4 of the total volume you've administered may have left the bloodstream and entered into that tissue. Making sure that you're reassessing patients and their vital signs is an important means of identifying when this fluid shift has occurred. Another rough correlation between the amount of crystalloid solution and blood. When we're using crystalloid solutions to replace whole blood that's been lost, generally 1 milliliter of blood is replaced by 3 milliliters of crystalloid. Now, hypertonic and hypotonic solutions may have some use in specific situations in the pre-hospital setting, but very rarely will they be the fluid of choice for trauma patients. Hypertonic solutions can include things like 7.5 and 3% saline, and they usually have more osmotic pressure than body cells will. Hypotonic solutions are very rarely used and have limited use in patients that have shock from trauma, but it could include things like distilled water, very low amounts of sodium chloride, Hypotonic solutions generally have limited use inside patients that are suffering shock from trauma. Isotonic solutions can include 3 major solutions, though using glucose-containing solution in patients that have shock from trauma is limited and not recommended. So we are left essentially with lactated ringers and normal saline. Okay, you may have the ability to infuse patients with blood or blood products, and you may have resources like calling for aeromedical evacuation that can bring that to you. Some things to know when we're utilizing blood and blood products. The general advantages that we get are both volume resuscitation and oxygenation and waste removal, as well as, especially if we're giving someone blood that has plasma in it, restoring some of their clotting capacity. All of these are optimal, but there are risks and disadvantages associated with it, making it not an ideal product for us to use on every trauma patient. Some of the disadvantages include true blood products might have a limited shelf life, in some cases up to 6 weeks, and then no longer be useful. They generally will require refrigeration or special equipment to ensure that it's still valid for use when it reaches the patient. And because we don't have, in the pre-hospital setting, safe means of making sure that we've typed and screened and crossed our patients for the type of blood that they're receiving and the type of blood that they have, we usually are only limited to the type of blood that's called universal donor, which means that it's something that is in very high supply because of that condition, and it's not the most common type of blood for donation. Now, when we're utilizing blood products, we generally will have to determine which of these blood products by our protocol or by our resources. When we're giving packed red blood cells and plasma, we usually give that as a ratio of 1:1 or 1:2. When we're giving blood products, we want to make sure that we're monitoring the infusion closely for adverse reactions. And if adverse reactions occur, we have a few steps that you'll use to remediate. Monitor patient's temperature. An increase in the patient's body temperature can be a sign associated with an adverse reaction, and save the bags that are utilized even if no adverse reactions have occurred. If the patient's going to have some infusion-related reactions, they can have a number of reactions occur. Frequent reactions that occur in patients that are receiving blood products include fever and chills, pruritus or reddening of the skin, and urticaria. Patients that have severe symptoms might include severe dyspnea, red urine output, and it's generally very frank red, high fever, and altered mentation. If the patient has adverse reactions, we want to stop infusion immediately. We're going to perform a rapid primary assessment and manage the life threats that are presenting in that patient as soon as possible. The patient's receiving facility should be notified early that an infusion reaction has occurred so they can prepare resources and manage on arrival. Finally, not only saving bags, but save all equipment that was utilized after it's been discontinued from use for the patient. This will be to inspect it to make sure that there weren't other types of pathogens or blood packed inside this device. Fluid therapy isn't useful in all patients' condition in trauma. In fact, we should have a reason for starting an IV, and one of the reasons might be for direct fluid therapy. When we're utilizing fluid therapy, there's a few different pathways that we'll take to make sure that we're meeting management recommendations in patient condition. A big pitfall, though, unfortunately, is in over-resuscitation, over-volumizing patients when resuscitating and causing hemorrhaging to get worse, blowing out any clots, and diluting the clotting cascades in patients when we're limited to only crystalloid solutions. Let's look at a couple algorithms that we can utilize to help manage patients and meet volume resuscitation protocols. So these are written out in the PHTLS 9th edition. This is the uncontrolled hemorrhage diagram, and a few of these are going to actually be all part of the same figure, figure 3-20 on page 80 of the 9th edition. Let's look at the uncontrolled hemorrhage algorithm. Now, the uncontrolled hemorrhage algorithm is going to be very useful for patients that are in a condition in which they've got internal bleeding occurring that we can't fix. That's essentially the hallmark of the uncontrolled part of this hemorrhage. Now, you can see here that this is separated by class 1 and class 2 shock on one side and class 3 and class 4 on the other. Recall from our previous lecture on bleeding, what was the vital sign that separated class 2 from class 3 shock? Said another way, what separates compensated shock from decompensated shock? Well, the blood pressure is the vital sign that signals that the patient's no longer compensating for the volume of blood that they've lost. If the patient's in class 1 or class 2 shock, their blood pressure is probably normal. When the patient enters class 3 shock, though, their blood pressure is likely to fall below 100 systolic. Now, when we volumize patients with crystalloid solutions or any non-blood solution, what ends up happening are some negative consequences. Those negative consequences that we'd like to avoid will include decreasing the patient's clotting ability by diluting the bloodstream and increasing, unfortunately, the patient's pressure and blowing out or dislodging clots that have formed inside the body. If that occurs, the patient's bleeding will continue to get worse, and we may still be quite a ways away from definitive care. So if the patient's in class 1 or class 2 shock, we've basically identified that they're compensating just fine. Their blood pressure is likely to be normal. So we can start IVs, and we can use that for fluid resuscitation later if things change, or we can use it for med resuscitation if that's what's required. We want to try and keep that IV, though, at TKO or KVO rate and not give them large amounts of volume. Small amounts of volume to these patients might cause them to lose those clots that they've formed. Now, in patients that are in class 3 or class 4 shock, they're decompensating. So we have to do something, but we don't want to overdo it. In some schools of discussion, this is called permissive hypotension. Now, remember that the MAP is the preferred measurement, but if we only have systolic blood pressure and no means of calculating a MAP, we do have values that loosely equate. You'll be most accurate, though, by achieving, with your IV, a mean arterial pressure of 60 to 65 millimeters of mercury. Roughly, that equates to a systolic blood pressure of 80 to 90 millimeters. So you notice that we are not trying to increase their blood pressure to a value greater than 100 millimeters of mercury. In fact, doing so will cause the onset of these negative consequences. So we're permitting the patient to have a lower blood pressure, permissive hypotension, when they're in decompensated shock. And remember that a mean arterial pressure of 60 to 65 is the minimum pressure that's required for end organ perfusion. In some cases, patients will require resuscitation for CNS isolated injuries. So when we're talking about here are central nervous system injuries, injuries to the brain and spinal cord that don't involve shock in other parts of the body. In these cases, we want to give them a higher rate of perfusion so that we can allow the central nervous system cells to receive the appropriate amount of oxygen that they need to survive the injury. The systolic blood pressure here of 90 millimeters of mercury should be tolerated. But if it is a spinal cord injury, you might want to consider titrating a MAP, not systolic blood pressure, but a MAP of 85 to 90 millimeters of mercury, which may be higher than we would see in our uncontrolled and controlled hemorrhage algorithms. The controlled hemorrhage algorithm here, again, part of figure 3-20, page 80 of the 9th edition of PHTLS. This separation is if we have a patient that has an external hemorrhage and we've controlled it, so we've gone through that other algorithm. Once we get to the IV section of the controlled hemorrhage algorithm, then we start using this one. So if they're in class 1 shock, right, so they've lost generally less than 750 milliliters of fluid. If they're in class 1 shock, we continue by giving them IV TKO. They're probably, if they stay at that level, it may be that their external controlled hemorrhage was the only hemorrhage they have. Now, if the patient's in class 2, 3, or 4 shock, we do have to be very cautious, again, because we may not know whether or not they have an internal bleed at this point. We controlled external bleeding, so if that was the only injury they had, then controlling external bleeding should stabilize their vital signs. In fact, if we give them fluids, then they should only improve because the circuit is closed. If the circuit is not closed, meaning there's a hole somewhere within the body that's leaking fluid, then their vital signs will not stabilize for very long or may not stabilize at all. That's the concept behind this. So in classes 2, 3, or 4 shock, we want to titrate the patient's warmed IV fluid, so again, 102 degrees Fahrenheit solution if possible, and we're going to give a bolus of up to 2 liters, and that can be in 250 milliliter increments if necessary, monitoring the patient's blood pressure and vital signs. Once we get that initial up to 2 liters in, and we've reached the systolic blood pressure of 80 millimeters of mercury, we want to stop for a moment and see what happens. If we've done that fluid challenge, essentially is what we're trying to do, once we've done the fluid challenge, if the patient has a rapid response, meaning their vital signs went back to normal, then we know at that point that their internal hemorrhaging is very unlikely to continue. They may just have, again, an external hemorrhage, but lost so much volume that it put them into one of these classes of shock. In that case, we want to maintain our fluids until the patient's heart rate is below 100, meaning cardiac output is compensated, and the systolic blood pressure is greater than 100 millimeters of mercury in the adult. Now, if we go the other way, though, if we do the fluid challenge up to 2 liters of fluid, or we get to that blood pressure rather of if we do our fluid challenge and our systolic blood pressure is reached 80 millimeters of mercury, and when we take a pause for reassessment, we see no response at all. It continues to stay low or decline. If there is a response, it's either very little or transient. It doesn't last very long. In those cases, we have pretty good suspicion that the patient has internal bleeding. What can happen in the case of a patient that has a transient effect, it may be that we gave them fluid, but the amount of fluid we gave was just enough to stop their clots from functioning, and they start to have a decrease in vital signs once they resume bleeding internally. In some cases, though, they'll be too far down the decompensated range, in which there will be very little or no response. In those cases, we're going to work to allow the patient to have relative hypotension, permissive hypotension. We're going to titrate our IVs to maintain a mean arterial pressure of 60 to 65 millimeters of mercury, or systolic blood pressure of 80 to 90 millimeters of mercury. These patients need to be evaluated in the hospital, and we're considering that their vital signs have changed because they have a massive internal hemorrhage. When managing our patients, it'll be important for us to realize that when we're giving that fluid challenge, essentially, our goal is to get to that 80 millimeters of mercury. We might do so by giving small boluses at a time. Those can include 250 to 500 milliliter boluses, but our intent is to give up to 2 liters, or we bring up that blood pressure. Pediatric patients, we generally will give them bolus of 20 milliliters per kilogram. Now, there are some recommended systolic blood pressure benchmarks, but remember that MAP will be our better indicator of end organ perfusion. Often we'll have our hands full with patients that are suffering shock, and unfortunately, it's hard for us sometimes to think about the long-term survival of the patient because we're focused on the short-term survival. Well, in managing our patients aggressively, identifying the presence of shock early, managing getting the patients to definitive care as quickly as safely possible will help prevent some of the later effects of shock. Because of the DIC and the washout phase that can occur in shock, DIC being disseminated intravascular coagulopathy, those things will create microembolisms and a bunch of waste that can impact some of the organs in the body. Acute renal failure can occur. Part of that is from a decreased perfusion to the kidneys, and the other might be that it's receiving too much toxins and overloaded. Acute respiratory distress syndrome might occur, where leaky capillaries are allowing fluid to enter into the lungs. Hematologic failure, and unfortunately, multiple organ dysfunction syndrome. So in managing our patients and recognizing their needs early, we can do something to work on the patient's complications of shock while we're resuscitating through our normal treatment. Ways to minimize those complications, though, include assessing for shock. Assume hemorrhagic shock is present until proven otherwise when we have patients that have signs of shock but no external cause of shock that we can find. Remember that cardiac output and tissue oxygenation are going to be impaired early, with our early vital signs changing in LOC and ventilatory rate. Ventilatory rate usually goes up a little bit, and the LOC will become not necessarily going down, but become anxious as an early sign, which can be easy to miss. We want to make sure that we're restoring and maintaining after managing major bleeding, airway, ventilation, and oxygenation, and finally, working on circulation to prevent hypothermia. Transport patients without delay and try to minimize our scene time to less than 10 minutes in critical trauma patients. Now, we've wrapped up most of our conversations surrounding shock management, but let's wrap up with one last concept. We're going to talk in this last few sets of slides about traumatic cardiac arrest. PHTLS's 9th edition has a very useful table and section and reading that covers when we should resuscitate and when we should discontinue resuscitation when patients have suffered traumatic cardiac arrest. So generally, we will resuscitate, do resuscitate when patients have general signs of life present. Those are going to include things like spontaneous movement, ventilations, pulse, or blood pressure. Also, we do want to resuscitate patients if they have limited vital signs, but when we evaluate their rhythm, we find that they're in narrow QRS complex PEA with normal or tachycardic rhythms. Those patients have a higher chance of survival, so we should resuscitate them. We'll find, though, that patients are less likely to survive if they have PEA, but we find wide complex QRS with bradycardic rhythms. And another reason to resuscitate includes managing patients with penetrating thoracic trauma with signs of life. If they have limited signs of life, but they have a QRS complex that's narrow and PEA with normal or tachycardic rhythms, and the patient can benefit from ED thoracotomy, those patients should be resuscitated to get them to that point where ED thoracotomy may reverse their trend. Now, generally, we can terminate resuscitation in patients in which we see that their ECG is deteriorating despite CPR, or we go from a patient that has a narrow QRS complex PEA with a normal rate, and they develop a wide complex PEA with bradycardia. Again, those patients are not likely to survive. Finally, terminate resuscitation. You can consider terminating resuscitation based on your local protocol, of course, when patients have viability that seems to be diminishing despite our resuscitation efforts, CPR, for example, for 15 minutes or more. All right, guys and gals, we've wrapped up now. So these are the references that we utilized in making this lecture series. I highly recommend that you review the PHTLS 9th edition published in 2020 by the National Association of EMTs. Let us know in the comments, give us a like, and subscribe. If you have any questions or topics that you'd like to see us cover, just go ahead and put those into the comments below. All right, stay safe, everybody.